Hello, and welcome to another live broadcast with MedStar Health. My name is Amy Cameron, and today I'm joined by Dr. Keith Kowalczyk, urologic oncologist from MedStar Georgetown University Hospital, and Dr. Pamela Randolph-Jackson, radiation oncologist from MedStar Washington Hospital Center. Today we're discussing prostate cancer. We'll discuss diagnosis and staging and the treatment options available for early stage prostate cancer. We'll talk about surgical interventions to advanced radiation techniques. Then we'll talk about treatments available, how treatments work, and what patients can expect. So if you'd like to learn more, then stick around. Give us a like to let us know you're watching, and share this broadcast with your friends and family. And if you have any questions for our experts, ask them in the comments below. Doctors, welcome, and thank you for joining. We appreciate you taking the time to speak with us and educate our viewers. Before we begin, could you tell our viewers a little bit about yourselves and your work at MedStar Health? Dr. Kowalczyk, let's start with you.
Yeah, sure. I'm a physician executive director of the urology service line throughout MedStar Health, chair of urology at MedStar Georgetown University Hospital, focusing pretty much purely on urologic oncology and robotic surgery.
Awesome, thank you. Dr. Randolph-Jackson.
I'm the chairman of radiation oncology at the Washington Hospital Center. I've been here for approximately 34 years, and I do mostly prostate cancer and GU cancers.
Thank you. Thank you. So let's get into the questions. What are the current diagnostic tools for early stage prostate cancer?
I guess I can start with that. It's pretty simple, in a good and a bad way. It's prostate-specific antigen, a blood test, commonly known as PSA, which you see it do its ups and downs in the media, but the fact of the matter is that it's still crucial for early diagnosis. Whether we actually get it in every single patient is a whole different story that is much more complicated. But you hear about these other tests, these other more expensive tests, 4K scores, things like that, which are essentially just super derivatives of PSAs. There's urine tests, but still the most cost-effective, easy way to screen and diagnose prostate cancer early as a PSA test.
Great. How do you differentiate between early stage and more advanced prostate cancer?
Randolph-Jackson, you want?
Basically, it's as you stated, the PSA. You look at the PSA level that kind of drives your risk assessment as well as the Gleason score, and you come up with your risk. And that will put you either in a low risk group, intermediate risk, or a high risk group, and you treat based on that risk assessment.
Yeah.
What tools? Oh, sorry. Go ahead.
Yeah, I mean, I guess we're saying, we're talking about early diagnosis, but also diagnostic tools before and after prostate cancer diagnosis are a little bit different. We're talking about two different things. So PSA remains the mainstay for diagnosis, and then if it's suspicious, then you undergo a prostate biopsy, and that's when you get a lot more information. So that's when you get your what's called the Gleason grade score, and that is how aggressive is the cancer. And as Dr. Randolph-Jackson said, how high is your PSA? Because after there's an elevated PSA, maybe before the biopsy, we may end up getting prostate MRI as well. And that's a very valuable tool if there's an elevated PSA first to see, number one, whether a biopsy is actually needed, but if it's an advanced or what we call locally advanced, which means the tumor has grown beyond the prostate a bit, we may be able to tell that from an MRI. And then the farther you get up through the risk groups, as Dr. Randolph-Jackson said, you can be low risk, which most of those patients, I don't want to get ahead of myself, but not too bad, up to high risk. And in those high risk patients, since we're talking about diagnostic tools, PET scan, PSMA PET scan has really changed the game in the last few years for determining whether or not the prostate cancer has spread or not.
And it's very useful also in the treatment of prostate cancer from a radiation oncologist's point of view in terms of fusion of studies and delineating disease.
There's a lot. So baseline PSA, PSA is the main thing, and biopsy, MRI, and PET scans PET scan especially is really changing everything that we do right now.
Okay, and I think you touched on my next question, which was what role do PSA levels play in diagnosis and monitoring?
Yeah, but everyone is always asking what a normal PSA is, right? And that's probably will come up, and the answer is I don't know. It's kind of up to you. Certainly above 10 is not what we like to see. but depending on your age, it depends on what your baseline PSAs are and what your age is. There's low PSAs in younger men. Your PSA should be about 1. In men who are in their 60s, it's normal to be around 3 to 4. If you're in your 70s, it's about 5 to 6. So you take all of that into account, and then a PSA over 10 will put you in the higher risk stratification.
But isn't it? It's also driven by the size of your prostate, as well as if you've had prostatitis and things of that sort. Your PSA can ride higher than what it would ordinarily be.
Why I like to say it's a red flag to do a little bit more, digging in, whether we get an MRI to evaluate that first before we go into that biopsy, because Dr. Randolph-Jackson is alluding to there's a lot of false positives, and you don't want to have a knee-jerk reaction.
And in terms of monitoring, if after treatment, you expect the PSA to go down over time. So the PSA is used for monitoring as well in that regard. After surgery, it should be 0, but after radiation, it slowly declines.
What are the current frontline treatments for early stage prostate cancer?
Well, early stage, again, we go by, nothing is cookbook medicine, but you look at first you risk stratify, like we said, low, intermediate, or high risk. And in most low risk men these days, we are trying to do active surveillance regardless. In fact, that should be standard of care, because when you look at a low risk prostate cancer, you're looking at a Gleason 6, PSA less than 10, very minimal biopsy involvement, so not many of the biopsies are positive. Those are almost never lethal. So we don't want to jump into treatment for over 50% of those won't need treatment. On the other side, 50% may, but you can still watch those patients for a while. When you get to intermediate risk and high risk, that's when you say, okay, we probably can't do active surveillance anymore. And I tell every patient there's a 1A and a 1B, and I'm not going to name which one's A or B. I don't think so. But like radiation and surgery are the 2 gold standards of anything else. And it's really a personal choice to the patient. I can't look at a patient and say your overall survival from radiation or surgery is going to be absolutely the same. They're both excellent treatments. It's just a matter of how old you are, what other side effects are you willing to manage, what you aren't willing to manage. So they're both excellent treatments. So I'd say any low risk, we want to do active surveillance. Intermediate, high risk, we're looking at one of those 2 treatments. We can talk about other types of things that are coming up, but that's to keep it simple. That's what it is, and it really comes down to personal choice.
I agree. And side effects management. I always ask my patients to look at the side effects profile on both and decide what they can live with. It's always an interesting thing. I had patients that I would have thought would have said, oh no, I definitely want radiation, actually go the surgical route. So it's really what you can live with in terms of the side effects. So I think the questions further down address those.
Mm-hmm. Yep. My next question is, what is the role of robotic assisted laparoscopic prostatectomy?
Prostatectomy.
Yeah. Thank you. In early stage prostate cancer.
Dr. Randolph-Jackson, you want to take that one?
No, that's yours. That's definitely yours.
All right, so it's a prostatectomy. I mean, that surgery for prostate cancer is a prostatectomy. That means removal of the whole prostate. People asking you to do partial prostatectomies, this and that. You can, but you really shouldn't. There are some people that have looked into that. So when we're looking at the classic gold standard removal of the entire prostate, over 90%, if not more, all done robotically now. When I was in training, it was in its infancy, and now robotics it's here to stay, especially for the prostate, because it just makes the surgery so much easier. It's really leveled the playing field as far as getting a good surgery from multiple different places, whereas doing an open prostatectomy before was very, very difficult.
Recovery's better too, though. Right?
Recovery's a lot better. I mean, yes, now it's certainly, I'm not going to get into that too much, but I mean, yes. So recovery, we're sending our patients home the same day now. The early cases, if they come later, we let the patient stay a night. I'm putting in suprapubic tubes, which is, after surgery, men need a catheter to drain their bladder, and usually that goes to the penis, which is not very fun. So I've started putting in suprapubic tubes. So, the surgery recovery now is just so much better than it was even 10 to 15 years ago. And the benefit of the robot is, there's not much bleeding at all. We don't, the risk of blood transfusion is less than 1%. As we've gotten better at these surgeries, if you go to an experienced surgeon, hour and a half, 2 hours of surgical time. When we were first starting, it was probably 8 hours, but we've been doing the surgery for over 20 years now, so we've got it. So the role is, it's one of the gold standard treatments alongside of radiation therapy. It has excellent long-term survival, excellent long-term recurrence-free survival, meaning the cancer won't come back. We tend to favor surgery for younger patients, and younger is a state of mind. I'm not going to put any ages out there, but because it's your chance to have one treatment, hopefully long-term, no recurrence, and you hopefully won't need hormonal therapy. You don't always need hormonal therapy with radiation, but sometimes you do. But we tend to do that for our younger patients versus radiation.
So let me ask you this: hasn't it improved in terms of impotency? I mean, with the robot, can't you?
I think we can spare nerves a whole lot better. I also don't think urologists are very, very good at objectively measuring erectile function. For sure, we can spare nerves so much better than we could when we did open. And if you look at most series, yes, it does look like sexual function is probably better, but it's really hard. You're comparing apples to oranges. Back in the day when we did open prostatectomies, we weren't following these outcomes quite as well as we probably should have. Continence, 1,000%. It's much better, much faster. Quality of life is overall better. Like I said, now these patients go home in one day. They're back to work. If they don't do any heavy lifting, they can be back to work within a week. So sexual function, I think, yes, anecdotally, it probably is better. Urinary continence wise, it's absolutely better. As far and convalescence wise, getting you back to your normal everyday activities, definitely better. But that's not really, we don't really argue open versus robotic anymore.
No, but it's nice to know because it used to be.
Yeah.
Okay, before we go too far into the treatment questions, Eric in the audience asked, how does BPH affect PSA? And could you define BPH first?
Dr. Randolph-Jackson was alluding to this. I'll let her go.
Benign prostatic hypertrophy, a big prostate. So I simplify everything when it comes to probably everything, but in any event, to me, it's the prostate makes PSA. So if you have a bigger prostate, you're going to make more PSA. So it might not, your PSA level may not be in the range of what is considered normal, which usually high normal is 4 nanograms per milliliter. So it might be higher than that, and it might ride that higher than that for the life of the person, and you might not have, you don't necessarily have cancer.
That's where the trend in PSA is important. So we'll have a lot of patients that come in with larger than average PSA. And as Dr. Randolph-Jackson said, the more prostate tissue you have, the more PSA you're going to have. That's normal PSA. But if we know there's a large prostate, if it looks like the trend over time has been the same, and your PSA is, say, 7 and you're in your 60s, that's higher. But if it hasn't changed, then we're okay with that. Also, if we've gotten an MRI or you've had a biopsy, we know your prostate size. And we can use the size to adjust for your PSA, and that's something called a PSA density. So it's a great question. Definitely that comes into play when deciding, whether you should go ahead and get a biopsy or not.
Okay, thank you. And going back to active surveillance, when is active surveillance recommended? You might have touched on this a little bit.
Yeah, Dr. Kowalczyk, you did touch on that. Low risk prostate cancer.
Yeah, definitely very low. I would say almost anyone that's low risk that's coming into my office, active surveillance is not only, I won't operate on someone with low risk prostate cancer. I just won't do it because I don't think I'm benefiting those patients.
And that's just watching the PSA levels.
It's more than that. I mean, it's an intense monitoring. So it's not like you've been diagnosed with cancer, we're not going to do anything. Some of these, I hesitate to call some of these cancers, I mean, they're kind of precancerous, but they could advance. So we get PSAs every 6 months. We do have to do some repeat biopsies. We repeat MRIs. With all of these new, diagnostic modalities, we're going to catch this before it becomes anything tricky. And what I tell patients is this is a treatment. Active surveillance in and of itself is a treatment. I'm not letting you go. In fact, I'm probably following you more than most guys I operate on, especially after 2 years. and there's no bridges burned whatsoever. But yeah, I mean, it does require hopefully, your urologist is a nice, person, and you get to enjoy their company every 6 months and tell a few jokes, but that's what it entails.
Exactly. You're just trying to watch it until you don't want it to get to the point where it's high risk and you have, disease that might be life threatening.
And it's extremely rare to go from low risk to high risk.
Exactly.
You'll go from low risk to what we call a favorable intermediate risk first. And even then, that's when you start to say, maybe we should treat, but even then it's not life threatening, but that's just when you've seen what this cancer wants to do. And, you take care of it and the outcomes are so great.
And what factors might lead to a shift from active surveillance to more active treatment?
Progression of disease, as was mentioned, if you see something on the MRI that's different, or the biopsy, the Gleason's on the biopsy, the repeat biopsy is different or higher, then that upstages you. And when you're upstage, you go to active treatment versus active surveillance.
And we use it's a lot of circumstantial evidence, pros and cons. There are some obvious cases. We do a repeat biopsy in a year. It's called a confirmatory biopsy. So somebody, I wouldn't call it an upstaging, but you basically hit another part of the tumor that looks a lot more aggressive than it was a year ago. And if that Gleason score goes up, and you use these risk stratifications we've been talking about to intermediate risk, whether it be because of Gleason score or your PSA goes above 10, that puts you in an intermediate risk, and hopefully not ever to a high risk, but that could happen. So it's Gleason score, it's changes in MRI, it's PSA, all of the above.
Okay. I'm going to pause and address our audience. If you're just now joining us, thanks for tuning in. We're speaking with our experts from MedStar Georgetown Cancer Institute, urologic oncologist Dr. Keith Kowalczyk and radiation oncologist Dr. Pamela Randolph-Jackson about the available treatment for early stage prostate cancer. We have more to talk about, so keep watching. Share this video with your friends and give it a like to let us know you're watching. And of course, if you have any questions, please ask them in the comments below. Let's move on to side effects and complications. So what are the common side effects of radiation therapy versus surgery?
Well, let me start with radiation. I always go through the worst side effects. And the only two that I really worry about would be radiation cystitis and radiation proctitis. And it doesn't happen often. It happens probably less than 5% of the time, either one. With rectal spacer, it actually has decreased to almost 0%. But if it happens to you, it's 100%. So I make sure that I go through a very tedious bowel regimen during treatment. So the entire treatment course, which reduces the risk even lower. So those are the main things. But you can also have urinary frequency, urgency, you can have diarrhea, and all of those resolve over time after you finished radiation. Our incidence of incontinence are very low, probably 4% or less. Impotency, we actually do better than surgery. I would say we're more in the range of 15 to 20%. And that's patients who are potent when they come. So your potency is dependent on how potent you were when you came in. We're not going to make you better, but we definitely decrease the likelihood of making you worse. So those are the main things you see. And of course, hyperpigmentation of the skin of the pelvis, which I really don't think much of. It resolves over time. How about surgery?
Yeah, well, surgery. So, anytime we're treating the prostate, it's urinary erectile function and bowel function. It's the three things you want to look at. So with surgery, it used to be the surgery itself. Now that we've done it robotic in one day, I mean, you still have to have a surgery, but risks, major complication risks are less than 3%. So then you go, okay, so what's it going to be long term? Erectile dysfunction is definitely the biggest immediate impact on a patient following surgery. A lot of that is age dependent. A lot of that depends on if we can safely spare erectile nerves that are attached to the prostate, and that depends how bad the cancer is sometimes. in my hands, if there's a younger patient that already has good erectile function, a younger 65, 60 and less, 80% chance I can get you back to where you are. But like Dr. Randolph-Jackson said, it's not going to get better. And unlike radiation, you're going to feel it right away. And it may take up to a year to get a little bit better versus radiation. It still will affect it, but it's kind of not right away. And it's a little bit more of a slower decrease than the average. So a lot of that, just like radiation, depends on, how good is your erectile function coming in, can we spare nerves, and at the end of the day, how good were the nerves to begin with, how good was your function. Incontinence, thankfully, as I was saying before, I think robotics has been a game changer. We do now what's called pelvic fascia sparing prostatectomy here at Georgetown, which preserves all the natural continence mechanisms. So, over 50% of men have zero incontinence, full continence right away. And the other 50% tend to get it within 3 to 6 months. So that's been an absolute game changer. Our overall incontinence rates are less than 3% right now.
But some of the great stuff too, though, is we have a very good pelvic floor department here. So,
Yeah.
And I send most people to them, and it's amazing what they can do.
Right. So that's become part of the regular regimen is pelvic floor physical therapy. Because building up those pelvic floor muscles even beforehand really, really helps accelerate recovery of continence, because many times men, understandably, don't know what a Kegel exercise is. And I think it's funny when I bring it up in the clinic, the wife or significant other is always like, "Oh, I can show you."
Yeah, we women do know about that. We women do know about that.
Yeah, or
care about pelvic floor therapy when it comes to women. We've not heard about it for men.
Yeah, so now it's really, we have a whole list of, prostatectomy specific, post-prostatectomy incontinence physical therapists. We send everyone that we send preoperatively so they can do it on their own. We always set them up for 6 weeks afterwards. And I'll be honest, probably 80% don't end up needing that, which is nice, but at least we set them up. But there's really no issues with bowel, with surgery. And I think most patients are surprised at how well they recover. But I would say I don't try to sugarcoat this at all. Erections, even if we can get you back to full erectile activity, might be a little bit of a journey rather than it's a marathon more than a sprint.
But you have a lot of drugs now that work, don't they? With after.
And what's even better is that so tadalafil, which is Cialis, sildenafil, Viagra. It used to be so expensive, and now with GoodRx, Mark Cuban Cost Plus Drugs, all these other ways to get the generics for cheap, we can give it to everybody regardless. It's cheap, and therefore, if you put everyone on a drug all the time, they're going to be better. And I start everybody on those. And then if that doesn't work, you can go to one of our sexual medicine therapy, specialists who can talk about maybe somewhat more invasive options, but we can work with it.
Yeah, I love them. They're very good.
Yep.
There are a lot of options to help with side effects.
Yes.
Are there any promising treatments on the horizon for early stage prostate cancer?
There's always treatments on the horizon. And I would say the big one right now is focal therapy. And that can be done in many different ways. Some people do focal laser ablation, some people do cryoablation. What's probably the biggest is focal HIFU, or high intensity focused ultrasound. It's in its infancy. I'll stress that this is not a treatment for everybody. And we still need a lot of data to see how well this works. It is not a treatment for men with high risk disease. I don't think it's a substitute for treatment for active surveillance either, which is what a lot of people would say. Well, let's treat this. It's not symptom free, and then if it recurs, it could make treatment difficult. I think it fits a niche, if you will, in those men who have intermediate risk disease. You can see it on MRI, not as healthy to have the other treatments. And it does show promising, it does show, some promising outcomes as far as it's not doing just active surveillance, it's not quite as invasive as surgery or radiation, but might at least slow down the progression of this cancer. But I don't think you can necessarily call that a sure thing for a cure for anybody. And we're doing it here under a study at Georgetown and Washington Hospital Center, so we're certainly looking into it. And I would say there's definitely a lot going on in the radiation world as well as far as how we cover.
For us, it's stereotactic body radiotherapy. That has taken off in terms of the treatment of intermediate risk, and it's now kind of bleeding into high risk cancers and the treatment of high risk cancers. The other thing is dose escalation, simultaneous integrated boost therapy, where you're boosting the nodule that is seen on MRI, and that's takes you back to the need of the MRI or the use of the MRI. You can fuse that with the CT, so you have better visualization as to where you're boosting the nodule, the known cancer, versus the whole prostate. So you treat the whole prostate, and then you're giving a higher dose to that nodule. The PET is also PSMA PET is also helpful in that means. You're also versus the dose escalation, we're also dose intensifying or retreating people who were treated with SBRT a second time or third time, if you can localize the nodule or the disease specifically where it is in the prostate. So those are the exciting things with us, as well as interstitial brachytherapy for prostate cancer. That's a new one that has been shown over time to be very good and successful in the treatment of prostate cancer. And now with high dose rate brachytherapy, it's a lot more convenient for patients. They don't have to hospital stay, which makes it much easier.
I would say most patients come in and say, brachytherapy was so popular in the 90s and 2000s. Everyone they know had seeds, and they ask,
Yes.
What about seeds? That's what brachytherapy is. And I would say it lagged behind for a long time because, correct me if I'm wrong, but it was mostly for lower risk patients. And now the high dose, it's changing the game.
Yes, and it also changes the game because the seeds were operator dependent. So if you did do a lot of them, you really weren't that good. But HDR, you can bend the dose, so to speak, so that even if you place the tubes incorrectly or not in the perfect position, you can bend the dose so that you treat the areas that need to be treated. So it's really an interesting time for radiation oncology.
Yeah, for both and also, the radiation treatments are shorter these days. SBRT, also known as CyberKnife, just letting everyone know that CyberKnife is not surgery, it's radiation.
Yes, CyberKnife is the machine.
It's just the machine. SBRT is the modality. It's clear for everybody. But anyways, and it's still, look, all of this is early convalescence. It's radiation as well as surgery. You have to go through these treatments, but with robotic surgery, patients do very, very well, and now the radiation treatments, are much faster. They're not 2.5 months anymore. So
right, we have shortened it, and actually did a study that showed that the outcomes are the same if you do 44 fractions, 28 fractions, 20 fractions, or 5, depending on your risk assessment. But and so most of the time, most radiation oncologists now will treat in 20 to 28 fractions. The rectal spacer has made a big deal with us in terms of saving the rectum, and actually studies have shown that it improves the outcomes for potency and for the bladder side effects. So yeah, it's really a big thing.
Our viewer Eric had another question, and you did just mention CyberKnife treatment. So he was hoping to get a little more information about CyberKnife.
So CyberKnife is in radiation oncology, we have modalities. The modalities are stereotactic radiosurgery, okay, or we have something called IMRT, which is different from VMAT or rapid arc treatment. And then we have 3D conformal and we have 2D conformal. So we have a number of modalities. The CyberKnife is a machine that delivers the modality of stereotactic radiosurgery. Does that make sense? So most facilities have one modality or one machine or another. So we have the Edge. There's a Gamma Knife. There's something called the Zap. There are a number of machines that do the same thing, deliver. And so the definition of stereotactic radiosurgery is that you're delivering 1 to 5 fractions. So if you're delivering 6 fractions, it's not radiosurgery. It's 1 to 5 fractions. And usually it can be every day, but most places will treat every other day to allow for sub-lethal damage repair of tissues. So hopefully that answers his question.
And CyberKnife is not surgery.
No.
A lot of people come to me for that. And exactly as Dr. Randolph-Jackson said, like CyberKnife is SBRT, stereotactic body radiation therapy, excellent treatment for those that can get it. But calling it, it's like saying that I do a Da Vinci prostatectomy rather than just robotic prostatectomy, because we use
Exactly.
It's just the modality. It's just the machine.
It's the machine. And radiation oncologists go into radiation because we don't like surgery and we don't like blood. So, of course, it's not. But we like the cool names.
Yeah, I think put that word knife in there. Use this people. Let's talk about interdisciplinary collaboration. So how do you collaborate with other specialists like radiologists, oncologists, or sexual health specialists for comprehensive patient care? And you've touched on this a little bit about pelvic floor therapy and all that.
It's super important. As you can see, we're going back and forth, and everything we're mentioning is a feasible treatment for prostate cancer, a very successful treatment of prostate cancer, but you get lost in this, world of what do I do? What do I choose? And that's where look, if you go in to see a radiation oncologist or vice versa, if you go in to see a urologist, that doesn't say and if you haven't already seen a radiation oncologist, you need to see a radiation oncologist and vice versa, then I would think twice about that, or at least be offered. If you choose not to, okay, because all of these are great options that depend on you. And I know about radiation, but I can't tell you what that experience is like. Dr. Randolph-Jackson that has to do that. So you're seeing, there are some clear-cut cases where we know who needs to do what, but both at Georgetown and Washington Hospital Center, we have what are called tumor boards for maybe more advanced cases that will require surgery plus radiation plus hormonal therapy, which requires me, it requires Dr. Randolph-Jackson, and it requires a medical oncologist. So it's extremely important to have a multidisciplinary approach. And then sexual health, we're lucky to have some urologists that specialize that here at MedStar, as well as other places that can help afterwards.
Yes, I love Dr. Vincontessa. That's where I send everyone. But I would agree. I would say at both of our places, we have a tendency to see everyone. So every patient that comes through, we'll see a urologist, a radiation oncologist, plus or minus a medical oncologist. And it depends in terms of the medical oncologist. Sometimes I think the urologist can double dips when it's something like Lupron injections, a single shot of Lupron, versus if they need something a little bit more tailored and as we go up the risk stratification. But yes, it's always multidisciplinary. I would have to say that it's a great team here and at Georgetown in terms of how we do things.
Yeah, I think it's important to define the roles too. So I'm a urologic oncologist, Dr. Randolph-Jackson's a radiation oncologist. Then we have medical oncologists, which, I think most patients think, oh, cancer, I'm going to go right to the medical oncologist, which is absolutely nothing wrong with that. But in prostate cancer, it's actually, it's the urologist and the radiation oncologist that are really the primary people for that. Because we don't want to get it to a point where a medical oncologist is needed. A medical oncologist is for stage 4 advanced disease. They need hormonal therapy, possible addition of an anti-androgen pill, which would bring the testosterone down, possibly chemotherapy as well. So those are for very, very advanced patients. We didn't get into it too much, but there are so many advancements in the treatment of advanced prostate cancer now as well. It seems like every year there's a new standard of care that's breaking. Or even when men who are unfortunate and are diagnosed with metastatic disease, they come through us to get diagnosed, and we go with our medical oncology colleagues. And while the treatments are hard, we're able to treat these patients that before had no other options. So that's kind of just a little bit a touch on our medical oncology colleagues and where they are.
And I definitely want to plug in for the radiologist. I mean, every tumor board has their radiologist there looking at MRIs. We have our nuclear med physicians there looking at the PSMA PET scans and reviewing all of the imaging that a patient has, especially if there's a question of metastatic disease on one scan. What would be better, a better scan to get to delineate whether or not it is or is not cancer. So it definitely is a multidisciplinary team in terms of the treatment of each patient that we get at our institutions.
Great. One last question. What is the role of the patient's primary care provider in managing early stage prostate cancer?
I feel for primary care doctors because they've been told one thing and another back and forth, and there's a lot on our primary care physicians' plates right now. So they can't be an expert on everything. And especially with PSA screening, it is a wormhole where you go down. I think the most important aspect is that patients at least ask about prostate cancer screening. There's nothing wrong with getting a PSA checked and having your primary care doctor get your PSA checked at least once. Some may say, no, absolutely. In 2012, they said we're not supposed to do that. Well, that's outdated. And if you're at high risk, you still should be getting your PSA checked at least semi-regular intervals. So I think that the prime kind of message here is that PSA has decreased prostate cancer mortality over the last 20, 30 years. It has decreased metastatic disease. We're now seeing an uptick in metastatic disease because fewer people are checking PSAs. And look, PSA is not perfect. I'll be the first person to say that, but the role of the primary care provider is to figure out who is at high risk. So that's somebody who's African American, someone who has a primary relative with prostate cancer, so a brother or father, and who are in families with BRCA2 or BRCA1 genes. So that's a history of breast cancer and ovarian cancer in women. Those men are also at higher risk for prostate cancer. All of those men should be getting screened every year. Now, if you take them out, maybe we can screen every 2 to 3 years, and certainly, between 55 and 70 is really the sweet spot. But I think the role of the primary care doctor is really to catch these guys as soon as they possibly can and not blow off PSA screening, because that it still does save lives. And then just send them over to one of us, and we do a lot of things before biopsying. As we showed, we're not doing, we're not ripping everyone's prostate out anymore that has the first sign of cancer. We're doing MRIs, and we're making sure that we do what's best for the patient. That's not overtreatment. Overtreatment was a bigger problem than screening.
And in essence, that's how we get most of our patients anyway, is from the primary care physician, who notices an elevated PSA in a patient and then refers them off to the urologist, and then it kind of goes snowballs from there.
Mm-hmm. Emma asked a question. You talked about the different modalities, but who is a candidate for these types?
In terms of radiation? Well, in terms of radiation, I would say it's based on the risk. But if we're talking intermediate risk, those patients are candidate for both. It really depends to me on size of prostate gland and wishes of the patient. If you have benign BPH, I more likely would treat you the longer course than the shorter course. The shorter course being 20 to 28 days. That's kind of how I do it. It's an art form. Medicine is an art form, and everyone, if you ask any radiation oncologist the same question, they'll give you a different answer.
Mm-hmm. There's rarely one option for one patient. There's multiple options for multiple patients, and a lot of it depends on the size. I mean, with surgery, it's all right. Yeah, we can pretty much do surgery on anyone unless those patients are, unhealthy, and the surgery itself, going to sleep, is not a good idea. Other than that, if you can tolerate anesthesia, we can do surgery. It's just a matter, is it actually beneficial for you? Larger prostates are take a little bit more time, but no size limit for surgery.
Thank you. Before we close that, what message do you have for our viewers? Is there one thing you'd want them to walk away with after watching this broadcast?
I would say cancer is curable, and not to be fearful after receiving a diagnosis of cancer would be my main take home.
Yeah, and especially prostate cancer, even at late stages, which we don't want it to get to, their survival outcomes are great. What we want is for patients to be diagnosed early, be risk stratified early, and then have the appropriate treatment, which doesn't necessarily involve the worst thing imaginable, losing, having surgery, losing all your, sexuality, leaking urine. That is very, very rare. And patients do very, very well. But at the same time, we're here to help. We're here to listen. We're here to get you the right treatment for you. you. So I don't want people to, number one, be afraid when they hear cancer with prostate cancer. Of course it's scary, but this is an extremely curable, treatable disease.
Well, that wraps up our broadcast. Thank you so much, Drs. Kowalczyk and Randolph-Jackson, for joining us. And thanks to all of our viewers for watching and sharing your questions. For more information or to schedule an appointment, call 202-295-0513, and we'll add that into the comments below. And we'll see you next time. Thanks so much.
Thank you.
Thank you.